Welcome to our discussion on congenital heart defects. This is Module A of Nursing 203. I'm Stephen Holloway. We will be going through congenital heart defects today. We'll break it down into several small chunks for you. I'm going to start out with an introduction to congenital heart defects. Your reading assignment is your pediatrics book, POTS. And Chapter 25 is the main chapter to be read. The chapter will refer you back to Chapters 14 and Chapter 7. I do highly recommend that where it refers you back, you go back and look at those areas because it is important as we continue through the process of talking about congenital heart defects. Along with reading your pediatric book, there's some things you may want to go back to your anatomy and physiology and review. You need to know and understand the normal circulation of blood through the heart and through the body. Very important as we begin to talk about the different defects and how it affects the circulation and the flow of blood. Of course, you need to know the anatomy of the heart and related structures such as your valves, the septum, and different internal aspects of the heart. As we talked about, your POTS does go back to different chapters. I definitely recommend you go back to Chapter 7 and review the area on fetal circulation. Even though I'll talk about it a little bit, I do highly recommend you go back and read that for yourself. A couple of other websites you may be interested in is the National Heart, Lung, and Blood Institute, the National Institutes of Health. They do a lot of research and publish a lot of research articles related to these type of malformities. So it'd be a good place for you to go and read and do your research. The Children's Heart Institute actually has educational packets and educational videos for parents with children with these birth defects or with these heart defects. So it's a good place for you to go back and look at different avenues, different ways of teaching your patients and maybe learning yourself about this whole congenital heart defect process. Let's review just a little bit about fetal circulation. This comes from your POTS, Chapter 7. And then Figure 7.1 actually has a good area there for that. There's basically 7.1 tracks you through the whole process. It's a graphical representation. So get your book out, take a look at that. But remember that the umbilical vein is connected to the placenta. The umbilical vein brings the oxygenated blood from the placenta into the fetus. This umbilical vein connects to the fetus through the ductus venosus, and it has two connecting points. It connects first to the inferior vena cava and then travels on and connects again with the portal circulation. Now, as the blood enters the inferior vena cava, it moves upward toward the heart, and then once it enters the heart through the right atrium. Now, because the respiratory system is not active in the fetus, most of the blood needs to bypass the respiratory system or the lungs. So there's an opening between the right atrium and the left atrium. That opening allows blood to bypass the fetal lungs and move back into the systemic circulation. So that opening between the right and left atriums is called the foramen ovale. Very important in fetal circulation. There are some blood that does get into the right atrium that makes it down into the right ventricle and does get into the pulmonary circulation. That blood, it gets there and goes through the system, but then it's actually channeled back into the aorta through the ductus arteriosus, which is just a small opening, small vessel that connects the pulmonary artery to the aorta. Now, it's very important that as the child is born that these close up. Figure 7-2 talks about that transition from fetal life to that extrauterine life. This change begins to take place as soon as that child takes their first breath, as soon as that umbilical cord is cut. And what we see is these beginning to close up as we go along. Now, the ductus arteriosus actually begins to close as soon as it happens. It typically closes within 24 hours of the birth. The ductus venosus actually gradually closes over about 2-week time frame. and then the foramen ovale closes shortly after birth, but it really continues to undergo fusion in the margins of that opening there until early childhood. So you may have an area there that's open, and we'll talk about areas that don't close like they should as the whole process. We'll look at some of the congenital heart defects as we move into it. Terms you will need to know and need to understand as you begin to talk about fetal circulation. Of course, we've been talking about cardiac output since the very end of last semester. Remember that cardiac output is really nothing more than stroke volume times the heart rate. But really, cardiac output is the volume of blood pumped by the ventricles each minute. And this is calculated by multiplying the stroke volume, which is the amount of blood in the ventricles just before systole, just before the ventricles contract. That basically gives you the stroke volume. So stroke volume times heart rate. That stroke volume can be affected by the preload. And that preload is the amount of blood in the ventricles at the end of diastole, or just before the contraction of systole. That can be affected by the amount of blood coming back to the right atrium and the right ventricle. Can be from dehydration, can be from fluid overload. So many things can affect that preload. The other thing we need to understand is afterload. Really, afterload is nothing more than resistance against which the ventricle must pump. You'll hear the terms systemic vascular resistance or peripheral vascular resistance. And that's the force which the left ventricle has to pump to push blood out into the systemic system. We also measure pulmonary vascular resistance. As we look at pulmonary vascular resistance, that's the amount of force the right ventricle has to overcome to push blood into the pulmonary system. There are certain disease processes that increase that, cause pulmonary hypertension, and increase that vascular resistance to the pulmonary system. So all of those are very important. These become even more important as we talk about congestive heart failure, because when we're treating a patient with congestive heart failure, we will actually use medications to affect all three: the preload, the afterload, and the contractility. Again, just a graphic representation. Some of you learn better by pictures, and this is kind of a cute little way to look at it. Preload basically is pressure from the volume of the blood in the ventricles at the end of diastole, end diastolic pressure. Now, where have you heard that before? As we were talking about the pulmonary artery catheters, we're measuring end diastolic pressure. Preload can be increased in hypervolemia, regurgitation of the cardiac valves, and heart failure. It can be decreased if we have a hypovolemic state. That can be an actual hypovolemic, or it could be third spacing, and where there's not fluid in the vascular space, but fluid out in the peripheral areas. Afterload, as we talked about, is the resistance that the left ventricle and the right ventricle must overcome to circulate blood. We said that increased in hypertension and vasoconstriction. Understand that increased afterload causes an increase in cardiac workload. Another term that you may be familiar with from anatomy and physiology is the Starling's rule. Frank Starling's law predicts the stroke volume. And the stroke volume can be increased by increasing the stretch of the fibers, the cardiac fibers. So if you think about it, it's kind of like a balloon. If we put more fluid in, the more it stretches, the more it stretches. But if you've ever blown a balloon up, blown it up, let it out, blown it up, let it out, blown it up, and let it out, that balloon finally begins to lose its shape. It's not as hard to blow up, and it doesn't release the air as quickly. It's because those fibers in the balloon have been stretched so that they're not working. Think of it kind of like a worn out elastic. Now we're going to move into really talking about congenital heart defects. It's the number one birth defect when we look at all the birth defects, the congenital heart defects. There are different statistics that say how many children are affected. This one slide came from basically a support organization, and it says congenital heart defects affect 1 in 100 babies. Your book talks about, and the Nursing Reference Center both say that congenital heart defects affect about 8 per 100,000 live births. When we look at gender, it's about equal number male to female when you look at the total number of defects. Now, as we talk about specific defects, some of the specific defects are more prevalent in males and some are more prevalent in females. And we'll talk about that as we get to those different areas, and we'll talk about that a little bit more. Now, when we start looking at defects, understand that there are 35 known different cardiac defects, and they can range from mild to very severe. Approximately 1/3 of these children who are born with these congenital defects have a critical heart problem that requires surgery very early in life. And about 1/4 of these will require surgery before the age of 1 year. It's not uncommon to have several defects together. Many times, especially if we're looking at these critical heart diseases, there'll be more than one congenital heart defect. Think about it, and we'll talk about this a little more, but the fetal heart actually is almost fully developed by 8 weeks of gestation. Many women have no idea they're pregnant before that time frame, so there's typically not a lot of prenatal care or things that go on with those. One of the things to understand, the more critical the defect, the more trouble there is, the quicker they try to do surgery and take care of that issue. The actual etiology of most of these defects is really unknown. We do know that the embryonic structures don't close at birth, or the heart is formed incorrectly. Exactly why, we're not really sure. We do understand there are some contributing factors to this, and your book talks about some of the contributing factors. On page 850 in Table 25.1, called Conditions Associated with Congenital Heart Disease. Some of the contributing factors that you're probably already pretty aware of, as we talked about prenatal care for our patients, is we look at viruses, rubella, varicella, CMV, all can cause problems. We do need to look at genetics. We do know that these congenital heart defects tend to run in families, so if there's a first-degree relative, as we're doing some of our prenatal counseling with these patients, we'll need to do that. Medications, drugs, alcohol, all can cause a problem. When we look at fetal alcohol syndrome, we can see typically VSDs, ventricular septal defects, ASDs, atrial septal defects, and tetralogy of Fallot. If a woman has continued to take lithium during her pregnancy, we can see something called Epstein's anomaly, or ASD, atrial septal defect, as part of that problem. If the woman has used amphetamines during the time frame, we can see VSDs, PDAs, patent ductus arteriosus, ASDs, and TGA, which is transposition of the great arteries. All of those can be seen. Our patients are pregnant patients who have lupus. Their children are more likely to have a congenital type heart block, which is more of a delay within the AV system. We won't talk a whole lot about that. Maternal diabetes, we can see cardiomyopathies with these children. We see the VSDs and the transposition of the great arteries. All of those can be problems for those. Now, maternal age also can play a different age, especially, remember, we talk about Downs, and typically with trisomy 21 and Downs, we can see ASDs and VSDs and different types of defects that can go on from there. As we're doing our history, we'll talk about that. We need to talk about the children's. Turner syndrome causes problems. Trisomy 18 can cause some problems. Remember talking about Duchenne's muscular dystrophy. Those can cause some congenital problems. Typically, we see cardiomyopathy with those type issues with our patients. So, real important to understand that these defects are there, and as we begin to talk about our physical exam of our new patients and our history of our new patients, to ask about these processes. Now, this is just a normal heart. Remember how the flow of the heart goes. I want you to go back and review that. Remember basically that blood comes into the heart from the superior, inferior, and inferior vena cavas into the right atrium. From the right atrium, it goes through the tricuspid valve into the right ventricle, from the right ventricle through the pulmonic valve into the pulmonary vasculature, typically out into the pulmonary arteries, which then returns back into the left atrium. Comes from the left atrium through the mitral valve, then out through the aortic valve, into the aorta, into systemic circulation. Very important that you can trace the blood back through, because as we look at these congenital defects, the path of blood is very different as we look at some of these processes. This just kind of represents some of the different type pressures that you see within the heart. The numbers in the parentheses are the actual pressures that are measured within those chambers of the heart. And then the percentages is the percentage of oxygen saturation of the blood in those areas. And you can see that basically in the right ventricle side, the side that's deoxygenated, the oxygen is around 75%. And you can see that typically it is a lower pressure system. And that's because, remember, it takes less pressure to pump the blood through the lungs than it does throughout the system. You look into the left atrium, left ventricle, and aorta, we see that blood is typically saturated at 95 to 100%, and we see the pressures are much greater in those areas. So if you think about there might be a hole between the left ventricle and right ventricle, which way do you think the blood would flow as we begin to look at those type issues? As we look at congenital heart defects, it's broken down into 3 classifications. The 3 classifications are increased pulmonary blood flow, or what's called a left to right shunt. There is a decreased pulmonary blood flow, which is a right to left shunt. And then there's an obstruction of left ventricular outflow. And we'll talk about each one of these individually as we begin to process the different types of defects. Now, let's talk just a little bit about defects with increased pulmonary blood flow. As we talked about with the blood flows from the left to the right. So there's a left to right shunt. These are typically caused by abnormal openings or connections in the heart or the great arteries. These typically lead to congestive heart failure, increased respiratory infections, and to endocarditis. Typical types of these left to right shunts that we're going to see, the defects with increased pulmonary blood flow, are your atrial septal defects, or ASDs, your ventricular septal defects, or VSDs, the patent ductus arteriosus, the atrioventricular canal defects. Now, I won't be covering that in lecture. Go back and read about that in your book. It's less prominent, but I do want you to read about it. And then the truncus arteriosus. Again, I will not be covering that as part of lecture, but you are expected to go back and read those type material in your textbook. Now, the defects with decreased pulmonary blood flow, basically there's a shunting the blood from the right side of the heart, which is unoxygenated, to the left side of the heart, which is oxygenated, or a right to left shunt. What we see is mixed blood in the systemic circulation. So we have unoxygenated blood recirculating back without going through the lungs, going into the systemic circulation. This typically leads to hypoxia, cyanosis. Long term, it's going to lead to polycythemia, which is an increased hematocrit, and erythrocytosis. The defects with decreased pulmonary blood flow, the types that we're going to discuss, is called pulmonary stenosis and tetralogy of Fallot. There is also transposition of the great vessels. I'm not going to cover that in lecture. I do expect you to read it. And tricuspid atresia. Please go back and read about both of those in your textbook. The defects that obstruct left ventricular outflow, these cause increased afterload to the left ventricle in varying degrees, and that degree of obstruction basically plays into what symptoms that the child is going to have. What we're looking at is a decrease of systemic cardiac output, less blood, less oxygen, less nutrients getting out to the systemic circulation. The types that we're going to see with these children are coarctation of the aorta and aortic stenosis. You can also see hypoplastic left heart syndrome. I'm not going to, again, cover that portion, but do read about it. Again, not as common. You may see the coarctation. You'll definitely in your career see someone with aortic stenosis as we move into those areas. Now, children who have congenital heart defects typically have a combination of symptoms, a grouping of symptoms that you may see. Those typically include an increased pulse rate, increased respiratory rate, retarded growth, dyspnea, orthopnea, fatigue, and increased upper respiratory infections. Now, this just comes from the National Heart, Lung, and Blood Institute, looking at the different types of congenital heart defects. I'm not going to sit here and read this to you, but definitely take a look at the different types of heart defects that are out there. These are going to talk about obstructive defects, hypoplastic left heart syndrome, patent ductus arteriosus, some of the septal defects, some of the cyanotic defects, endocarditis. It really gives you a good breakdown of those. Just a good thing to read and to study as you're getting ready to read about these defects. So one of the things that we need to do as our patients come to us either in our clinics, in our emergency department, or in the hospital for their workups of some symptoms, we always want to ask them about their chief complaint. We want to know what brought you to the hospital. Try to get them to be specific about what's going on. Ask them about their presenting symptoms. When did these begin? How long has it been going on? Are these symptoms there all the time, or are they intermittent? What makes them better? What makes them worse? How severe? When I talk about how severe, if this child comes in with cyanosis, is the cyanosis there all the time? Does the cyanosis get worse with activity? If it's shortness of breath, what makes it better? What makes it worse? Can they lay flat at night to breathe, or do they have to sit up to sleep because they can't breathe? So look at all of those type issues. In our infant population, we really, and as we get even older, I wrote infant here because we tend to see these problems first in the infancy. But even with someone that's coming in with new type heart problems in our pediatric population, we're going to ask them about if the pre and postnatal natal history. We definitely want to know about the mother, any problems with the pregnancy. If they can remember the APGAR score, that would be great. Especially in our infants, we want to look what went on that prenatal history. Remember, we talked about the drugs that can affect, the viral infections that can affect all the development of these children. We want to ask them about eating patterns. One of the things that we see in these children, especially if they're having a lot of cyanosis, having a lot of trouble breathing, is feeding problems. They are having to use so much energy in their breathing that they cannot take in enough nutrition to keep up with the extra energy they're expending. But then also as they're sucking and trying to feed, they can't breathe. So it's kind of a no-win situation for the child. We're going to definitely weigh this child, get a length, get a head circumference, and we're going to plot all these out on our growth charts. We're trying to see, is there any failure to thrive? Are they staying within those normal standard deviations of growth and development as we're looking through? We're going to ask them about cyanosis. And don't ask them about cyanosis. Is their child turning blue? Are they having do their extremities turn blue? Now remember, in our infants, it's not uncommon to have some bluish cyanosis in the extremities in the very early ages, and some cyanosis in the periorbital region. But if they complain about constant cyanosis, more of a deep purple cyanosis, or they talk about cyanosis of the lip or tongue, that's much more significant and really needs to be documented. When does the cyanosis occur? Does it occur with activities? If so, what activities, and how long does it take to occur? going to get a good family history. Remember, we talked about that there's some of these tend to run in families. Find out, is there anyone in the family that's had heart defects? We talked about growth and development. Really want to look at those weight, height, length charts. But also, are they meeting the developmental milestones? Are they at the point they should be holding their head up and they're not? Those are some of the things that with the infants you'll need to be looking at. Our older population, our toddlers on up, what is their exercise tolerance? When most toddlers are out running, they'll keep running until they fall asleep. But these children can't tolerate that. They just kind of lay around. They don't want to do anything. They may move a little bit, but once they get up and moving, they maybe get cyanotic. They may get short of breath. So look at all those. We talked about the shortness of breath. Can they lay flat and sleep at night? Do they have to be propped up? When does the shortness of breath occur? Color changes we talked about. Ask the parents about, has this child complained of any dizziness, any heart palpitations? Have they passed out? All of those are very, very important things to attain in this history. So it's real important to get a good in-depth history on these patients. Now, our physical assessment, just like any other physical assessment, we're going to do our inspection, auscultation, palpation processes as we look at these children. Our inspection, just like always, we're going to do an overall appearance of this child. One of the things we want to look at is the facial features. Are there any facial features that could indicate some of these genetic variations? Also, are we seeing any cyanosis as we're looking at these children? We're going to look at the chest. Is there any barrel chest, any changes in the chest wall? What's the respiratory rate? How hard is the chest moving? Are we seeing any retractions on these children? Skin color, of course, we talked about, looking for that cyanosis. Looking for edema. If we're looking in infants for edema, we're not going to be looking for JVD. We're not going to be looking for dependent edema as much, but we may be looking for hepatomegaly. We may be looking at some paraorbital type edema in these. And as our children get older, we may see clubbing, fingers clubbing, as that deoxygenated blood, as we're seeing that hypoxia causing more problems. As we move into the auscultation, of course, we're going to auscultate the chest. We're going to listen to the lungs. We're listening for any type of respiratory issues, bronchi, rales, wheezes, any type of abnormality, any friction rubs. We're also going to listen to the heart. We're listening for murmurs. Remember, murmurs are nothing more than the blood going across some sort of rough type surface, really is what we're looking at. Typically, murmurs are related to valve problems or defects within the extra openings in the heart between the atrium, between the two atria, or between the two ventricles. We will definitely get murmurs. Now, I don't expect you to be 100% proficient at murmurs. I do want you to go back and review your 103 physical exam book. Know where to listen for heart valves. Where do you listen for the aortic? Where do you listen for the tricuspid? Where do you listen for the pulmonic? Remember Mr. King's ape to man references as you listen to the hearts. The murmurs are graded from 1 to 6, 1 being the lightest, 6 being the loudest. I don't expect you to be able to put your stethoscope on the chest and tell me that's a grade 1 or a grade 6. I would expect you to be able to pick out on an exam what would be a grade 1 or a grade 6 description. So go back and review that. That is in your book. Chapter 25, box 25-2, talks about classifying the murmurs by grades. So as we look at that, remember, not all murmurs are pathological. There is something called innocent murmurs. So we'll take a look at that. Also know that murmurs can increase in intensity with fever, illness, and stress. Also, as you're listening to that heart, listen to your S1, S2. Is there any splitting of the S1, S2? Or is there an S4? Listening for all of those. Go back and review what those mean. That's something you should already know as part of your health assessment process. There's just a little type thing to kind of help you remember about heart murmurs. There's two types, systolic and diastolic. The diastolic occurs during systole, and crescendo means it gets louder throughout systole. Decrescendo means it gets softer. You can have a crescendo, decrescendo type process throughout the systolic. So, again, I don't expect you to be experts. Understand that these murmurs can indicate stenosis of a valve, partial obstruction of a valve, regurgitation of either the aortic or the mitral valve, or septal defect, whether that defect be between the two atria or between the two ventricles. Again, our assessment, we're going to move on. Palpitation. Big thing is to check your peripheral pulses on these children. We need to look at those peripheral pulses, make sure that they're equal at all 4 points. You want to feel the heart rate. You want to check those heart rates and make sure things are good. We're also going to look at that abdomen. As we're doing our inspection, we're looking to see, do we see any protrusion of the abdomen as we're doing our palpitations. Hepatomegaly is one of the signs of congestive heart failure. We're also in looking at that abdomen, is this child emaciated? Are they not getting the nutrition they need? The other thing we need to look at is blood pressure. Remember, you must have the right equipment. The cuff must be the right size. You must have it in the right place. On these children, when they come to your hospital or when they come to your clinic for the very first time or come to your emergency department with cardiac complaints, you need to get blood pressure measurements in both arms and in both legs to do a comparison. And as we talk about coarctation of the aorta, you'll understand why we're doing that. Now, if we're doing these for hypertension issues, we want to make sure we're doing serial measurements on these children. A multitude of diagnostic tests that we'll be doing on these children. Table 25.2 really talks about, that is a mistype. Yes, it is. Table 25.2, where the murmurs is box 25.2, talks about some of the different types of diagnostic tests. Of course, we're going to be doing a pulse ox on these children. Probably going to get a 12-lead EKG on them. If they're having a lot of palpitations and they're stable, we may send them home with a Holter monitor or an event monitor. We want to get a chest x-ray. That chest x-ray is going to tell us about the size of the heart, if there's any fluid in the lungs. Those are some of the things we want to see. If this is a new onset murmur, we really want to get an echocardiogram. That's really one of the first things we want to do. Remember that echocardiogram is going to tell us about the function of the valves and tell us about the flow of blood. If there is a septal defect or regurgitation through one of the valves, we can see the backward flow of the blood, especially on these very colorful type electrocardiograms. So real important to get those for those. Now you need to understand these different exams as you will be explaining to the parents what will be happening. Again, cardiac catheterization may be something so that we can see how big is the defect, if there's a septal defect, is that ductus arteriosus still open, and sometimes as we try to close that ductus arteriosus, that's done through a cardiac catheterization process. Management of the child going through a cardiac catheterization is a fair amount different than taking care of a child an adult who has gone through the catheterization. Your book has a very good breakdown on taking care of that child. Be careful with these children, because many times these children who have had chronic problems, such as tetralogy of Fallot, some of the big problems, have been in and out of the hospital so many times, they can develop a latex sensitivity. So make sure you ask about latex allergies with these children. Remember, with the cardiac catheterization, these children can't be left NPO for long periods of time. We need to keep that shorter period of time. That's going to be the facility. Most places recommend 4 to 6 hours for that. Going to ask them about allergies to iodine contrast dyes, and many times you won't know on these children. When they come back, again, we're monitoring that insertion side of the catheter. If it's an extremity, we're going to try to keep that extremity as still as possible. Sometimes it's better to let the parents hold these children to settle them down if we possibly can, but they need to keep that extremity straight for 4 to 8 hours. We need to monitor their intake and output very carefully. Contrast material can promote diuresis, so that we need to make sure we're doing that. Remember, in doing a intake and output on a child who has not yet been potty trained, is using a diaper, you need to weigh that diaper before you put it on them, and then weigh that diaper after they urinate, and then subtract the difference, and that should give you how many milliliters of urine the child has put out. But very important that we're measuring those type things. Of course, we're going to be measuring their vital signs. We're going to be looking at their respiratory rate. Many times we have to sedate these children as they're going in, so I have to be very, very careful as we're doing that. Your book has some good photos of a child getting a 12 lead, a child doing an echocardiogram. The echo typically is not too big of a deal with those. I've seen some of the techs actually have little puppet type things that are, make the one look more like a little animal or something. The children really like it. But that cardiac catheterization, as our children get more 3, 4, 5 years old and have had multiple of these, it can be quite stressful for them. So real important to monitor those. Sometimes we'll get an MRI on these children. Don't see it as much, but it is something that you may have to look for. So that's where we're going to stop for introduction to congenital heart defects. We'll be back and we'll begin discussing some of the different specific congenital heart defects. Thank you.